Sinem Karipcin. Everybody calls me Dr. K. And I'm the director of the pre-pregnancy genetics program at Columbia University. So we are a multidisciplinary team of specialists, including genetic counselors, MFM geneticists, and doctors like you, Dr. Kaur. You're a part of the program, you're the extension, and Amanda, you as a genetic counselor, because we use the expertise of other specialties to give the patients their reproductive options. So that's what we focus on, helping patients choose the reproductive path that feels right for them. Thank you so much. And if I stand here, everybody will see me on the video as well. Okay. So first of all, I would like to thank you for the opportunity for speaking here, and also as the audience, I already learned a lot from the talk so far. And so we give the patients, when we counsel the patients in the pre-pregnancy genetics program, we give them all the reproductive options, which includes testing before pregnancy, which is embryo genetic testing. If you do, it's before the embryo is implanted. During pregnancy, prenatal diagnostic testing. You could test the embryo, the fetus. Even you could test it around 11 to 14 weeks with a CBS, and you could know the status of that pregnancy if you don't do IVF. And also you could test the child after birth. And we are also using our scientists' help at Columbia to review the right approaches are used. So it's not only clinicians, it's also scientists that has a role in our research and clinical care. And you could see the link here. I have no disclosures. So I'll first review the importance of establishing molecular diagnosis for reproductive options counseling, because we can only test for a variant that we know, okay? So if you get the tumor biopsy, or for individuals who have the full constitutional NF, they blood sample, or for mosaic individuals, other tissue samples, but it's important to get molecular diagnostic testing, and Dr. Morales will be speaking next about the importance of getting that tissue diagnosis in more detail. And we are going to define the role of IVF, embryo genetic testing, for de novo and inherited neurofibromatosis. And also we'll touch base on a sensitive clinical test to detect mosaicism that we apply on the sperm tissue that's useful for the neurofibromatosis mosaic individuals. Okay, so I'll discuss 3 clinical scenarios here. And in those 3 clinical scenarios, our focus will be, can we test the embryos on each clinical scenario? And the first clinical scenario, and these are all real patient stories, 23-year-old G0, meaning never pregnant female, and her 29-year-old male partner. They're trying to get pregnant in the last 2 years. They're interested in fertility treatments. Upon getting the detailed history from both partners, the male partner tells us actually he's clinically diagnosed with neurofibromatosis as a child and F1 as a child. But he never had molecular diagnostic test. And his father and also his brother has an F1 diagnosis, and he has a 50% risk that their child could be affected with neurofibromatosis 1. Can we test his embryos for it? Yes, we can, because he did molecular diagnostic testing, which showed the variant that is causing the NF1, the variant, pathogenic variant in the NF1 gene. And so we can test his embryos, and I'm going to give a full story of their IVF cycle and how it went as the case example. Second scenario, 34-year-old healthy male and his 28-year-old partner, and this is a partner that he had other partners before, other female partners, and he had fathered 3 children, and he has no signs of himself NF1, but 2 of his children from 2 different relationships are affected with NF1. So he carries it in his germline for sure, given his reproductive history. So there is a 50% chance that their child could be affected with neurofibromatosis. If we know the variant, meaning when we test the children, when we test his sperm, when we know the variant, can we test their embryos if they were to do IVF? Yes, we can, okay? So the third scenario. So 46, this is an NF2 case, okay? So 46-year-old male with history of vestibular, spinal, and trunk schwannomas, and his 44-year-old wife are interested in egg donation because wife is older, and they also want to know about their risk of passing neurofibromatosis to their children. So tumor from right calf showed a pathogenic variant in NF2 gene, and the same variant was not found in his blood cells, okay? So he's mosaic for it. But the same variant is present in 10% of his sperm cells. So yes, their children may be affected with NF2. The possibility of that happening is complex too, because they don't have any children before. But there is a risk that they could have a child with NF2. And so at Columbia Fertility, when a patient comes to us, we discuss embryo freezing with embryo genetic testing option. So for male partners who are affected with NF and they want to stop, they could also consider sperm donation. Some couples, they would not choose the route to do IVF for it, and they could decide to pursue natural conception. And for some individuals, they prefer not to do prenatal testing, and for some individuals, they prefer to know as soon as possible, and they would do CVS, placenta sampling, 11 to 14 weeks, as early as that, or they could choose doing amniocentesis, which starts around 16 weeks. That's the amniotic fluid sampling from the pregnancy, but that's after the pregnancy is established. So for female carriers without a partner, okay, they could choose to freeze their eggs to do testing on their embryos in the future, because those eggs could be used for IVF. Or they could choose, similar to sperm donation, egg donation to prevent passing this on. For female carriers, that pregnancy poses risk to the fetus or mother, so there are the patients that you both discuss with really like severe tumors that is having paralysis or just really significant health risks with pregnancy. They will be eligible for gestational surrogacy. So if there is a medical indication at Columbia Fertility, we allow gestational surrogacy. Gestational surrogacy means somebody else carrying the pregnancy for that individual. Embryo genetic testing for NF1. So I just will walk you through from A to Z the IVF embryo genetic testing process, and that's for the patient example number 1. So we'll finish her story. So when we discuss about embryo genetic testing for NF1, it's PGTM, okay? M is for monogenic disorders, which stands for single gene disorder. So that nomenclature has changed in 2017. A lot of the doctors that are from my generation or before in other specialties, probably they're used to the terms PGD, PGS, so that's replaced by dose PGTM, SRHLA. In this context, we are speaking about PGTM. So the indications of PGTM are expanding. We could test the embryos for new variants of the parents, okay? So if in this audience, if there are some mosaic individuals, okay, or individuals who have this as a new mutation for them, just know if we know the variant, in most cases we could test the embryos for that condition. And also in case 2 example that I gave, the man only had it in his sperm, probably. And 2 children affected, so we could, if only the children are affected, we could test the embryos for that variant most of the time, depending on the variant, okay? So again, this is Dr. Morales will get into the importance of the molecular diagnosis, but molecular diagnosis is essential. In most cases, if we know the variant, we can test for it, but we need to get that report. Okay, so IVF, so this 23-year-old woman with her 29-year-old partner, you already know the story. So he proceeded with the molecular diagnostic testing. In his blood sample, he has it in all his tissues. He inherited already from his dad, and it showed a pathogenic variant in the NF1 gene. So they're already struggling with infertility, so they wanted to do IVF, and they wanted a large family, so they wanted to as well test their embryos for NF1. So I'm going to walk you through the PGTM steps. This is just an outline slide, but we are going to start with growing eggs. Then we are going to collect the eggs. We are going to put the eggs and the sperm together. We're going to culture the embryos and biopsy the embryos and freeze them. After we know the genetic status of the embryos, we are going to transfer to create the pregnancy. So let's walk through all of these steps one by one. So in 2024, when we do IVF, we bring the embryos to extended culture. So this is a 1-week stage embryo that you see. And we actually biopsy the embryos, like we biopsy there what makes the placenta in more than 80% of the cases, okay? Most of the time, this testing is for checking things like Down syndrome, aneuploidy testing, okay? But at Columbia Fertility, because of the pre-pregnancy genetics program, we're a referral center, we see more single gene testing. But this is just to show you. And then we'll freeze the embryos that we biopsied So it's more than 90% of the cycles are with embryo freezing. So this is to show you nothing that we do is experimental. It's what we do in the IVF lab every day, okay, with lots of data behind it. So when we are analyzing this biopsy sample, we are analyzing for the NF variant. The patient is at risk of passing on. That's the only difference. We are not getting another biopsy, it's just analyzing for something additional. So how does it start? So everything starts with the PGTM setup, okay? So when we biopsy an embryo, it's about 100 cell structure or so, okay? So it's different when you are getting tumor biopsy, just like the biopsies that you do, Christopher, that is a lot of tissue, right? Or if you get a blood sample, it's a lot of tissue, thousands of cells there. Here, when we are working with 100 cell structure and when we are biopsying 5 to 10 cells from it, we need to amplify, like make that genetic data more, amplify that data to get the exact information. And at most times we look at the linked markers surrounding the area of the variant. So there is going to be a family specific setup, okay? So we are going to get ready to test for the exact variant, okay? We are going to, if it's something that's present in like your family that you are asking the question, so you'll your family members, your dad was affected, so just a cheek swab from your mom could be okay. It's some family members, but if there are no family members, in some cases the arrested embryos or other embryos that form could serve as genetic data to get accurate information. So how does the IVF cycle? Then after that setup is complete or underway, we could start the IVF cycle. Okay, so once we know that we are ready to test the embryos. So how does IVF cycle work? How does ovarian stimulation, how does growing more eggs work? So in a natural cycle, a woman grows 1 to 2 eggs, okay? And this is how the ovary looks in a natural cycle. And in an IVF cycle, we give medications, the nutrition to those eggs so that we make multiple eggs grow, okay? And the ovary looks just like this. So that stimulation is about 2 weeks, okay? Followed by collection of the egg. Going through this process does not decrease an egg reserve of a woman. Actually, we collect the eggs that would otherwise die off, okay? And the risks are minimal. There is a risk of hyperstimulation, okay, from responding too much. There could be fluid electrolyte changes, but that risk of severe hyperstimulation is quoted by our society is 1%. But in the case when we are freezing embryos, and at Columbia Fertility we monitor the patients very closely to make sure they are responding enough but not too much. So that risk of severe hyperstimulation is very, very small. And the risk of bleeding and infection is also less than 1 in 1,000. So how do we collect the eggs? The patients receive a mild anesthesia. They breathe through the procedure. They receive sedation. They're breathing on their own, but they're sleeping. They don't feel anything. They don't feel any pain. So we collect the eggs under ultrasound guidance and sterile technique, and we aspirate the follicular fluid, and we collect the eggs in that. Every follicle has 1 egg in it. And this is like considered this as the house of an egg, where as the follicle. We collect the egg. Every follicle has one egg in it. Depending on the quality and the maturity of the egg, it will come to the needle. And then we'll pass this in tubes to our embryologists. And then embryologists will count the eggs, and this is how the egg looks like with the surrounding cells around it. And then and then we need to inject the sperm inside the egg. Okay, so because in single gene testing cases, we need to get the information not from the cells surrounding the egg or not from the sperm surrounding the egg. So we need to get the information from the embryo. So ICSI will be performed, injection of the sperm inside the egg will be performed in all PGTM, in all embryo genetic testing for single gene conditions. Due to time limitations, I'm not going to go through this video, but there's a video here to watch the first week of the life of the embryo and the culture conditions. And then this is the blastocyst 1 week stage embryo that's colored to help us identify what makes what. So here what you see in green is what makes the placenta. What you see in red is what makes the baby. When we do the embryo biopsy, we biopsy what makes the placenta. And we obtain 5 to 10 cells from it, okay? And then we keep everything in the embryology lab and freeze the embryo right after, okay? We just only send the biopsy sample for analysis to the PGT lab. And from the same PGT, from the same trophectoderm, like placenta biopsy sample, the analysis for aneuploidy and analysis for NF can be performed. So no additional biopsy is required. But this is something that requires good embryology lab conditions, good ovarian stimulations, experienced embryologists, and also diagnostic platforms, right lab. So that diagnostic platforms that will give highest diagnostic accuracy, so right lab techniques needs to be utilized for the analysis too. So that's all of those steps requires expertise, okay? And so what happened to that young couple? And so we collected 32 eggs when they did their IVF, and 21 were mature and injected with the sperm. From that, there were 14 embryos that were formed, and for those 14 embryos, we watched them to 1 week stage, and 10 of them made to the 1 week stage to be biopsied for analysis. And this is their PGT-M results, okay? So the eggs are numbered, the embryos are numbered from the egg that they're coming from. That's why some numbers are skipping there, okay? And here you could see the PGT-A results, the aneuploidy results, okay? So they're very young, so all of their embryos were normal, okay? But as the woman ages, the embryos will be affected with chromosomal abnormalities like Down syndrome. So you know the gender of the embryo, okay, but you could, as a patient, you could say, I don't want to know, so we'll give the results upon request there. And then the NF1 variant analysis, you could see there, so the embryos that carry the variant are called heterozygous positive, and the ones that are negative are listed in blue. So they had their first embryo, and they had their son, and they are back for baby number 2, so they're having their transfer this week. So just to overview, so there is a setup which takes about 5 to 8 weeks. So the PGT lab getting ready for DNA samples from family if available, and getting the diagnostic reports, getting blood samples from the couple who are interested in testing. So that's set up 5 to 8 weeks. And then ovarian stimulation about 2 weeks. culturing the embryo is about a week, okay? And from there on, the labs analysis of the sample takes about 3 to 4 weeks, okay? So cost, that comes up as a question, so I wanted to put there because a lot of individuals think that it's not going to be covered by insurance for them. Maybe 6 years ago, when when we first started the pre-pregnancy genetics program, that was an issue. But the trends changed so much that I have now several examples of patients who don't have an insurance that covers IVF. In their policy, it's listed no IVF coverage. We write letters of medical necessity with our genetic counselors, just really expressing this was the choice of the patient, there's a genetic indication, and then insurance agrees on paying for it, okay? But Medicaid or insurance like $11.99, so there are always some insurance that won't cover any of that, okay? Those patients can be seen at our fellow clinic, and as pre-pregnancy genetics program will supervise their care, those patients, so all the fellow clinic patients that are doing PGTM, I'm the attending that they report to. So if any of you have a couple that's interested, don't presume that they're not going to be able to afford. Just pass on the information to me, and I put some brochures at the entrance of our program. Just if somebody is not ready, they could just scan the QR code, and when they're ready, they could reach to us directly. So this is just really a personal choice. We respect that. Some people may not be ready. Their hands may be full with their child or with their own medical care. So, but this QR code helps directing them to the pre-pregnancy genetics program. But if you're a patient, you think, don't presume that they're not going to be, because there may be a way. And Dr. Garilik, she, in the opening talk, I was really excited because we actually give, with our fellow clinic, we just really do this with 50% lowering the cost for the patients. We just do the cycles just to cover the embryology culture conditions, and the PGT lab also gives a 50% discount to the patients compared to any other self-care patient that comes to the attending clinic. But for a lot of individuals, that's still a lot. So some financial support would be wonderful. So I would love to discuss this further for this community, helping them together. So feel free to, summary, feel free to pass this along. We'll make this work for them if that's the choice for them. So, but also there are several financial support possibilities within communities too. So I put some examples, okay? So within Jewish community, A-Time, Bonai Olam, they give significant support, financial support. There are Baby Quest grants and other grants, they may be possible. So I'm leaving brochures, and you could follow this QR code too. And as a last word, I will talk about testing the sperm for neurofibromatosis variants. It's only going to be applicable to men who are mosaic for neurofibromatosis. But we could test the sperm with basically tagging each sperm to increase the diagnostic accuracy. So, but all we need is the molecular diagnostic report. We don't need any other samples, just the molecular diagnostic report that shows the variant. And I also put the steps for study enrollment, but you could just basically reach out. If you scan the QR code, that will also guide you through the link for this sperm sensitive assay for mosaicism. And okay, so conclusions. Pre-implantation genetic testing is an option for families or individuals affected with NF, okay? This is a very personal choice, okay? So they, all of you, they're affected with NF, you have several reproductive options, and this is one of the paths. And in most cases, if we know the variant, we can test the embryos for that variant, and also SAM, which is sensitive assay for mosaicism. It's helpful for detecting sperm mosaicism if the sperm is affected in mosaic neurofibromatosis individuals. And this is my partners, my wonderful partners that I practice with at Columbia Fertility, and I would like to thank them for the support on the patient care. And I also, I did not include our genetic counselor's photo there, and I would like to also thank Dr. Katie Baptist, Dr. Wapner, Ron Wapner, Karina, Nina, Stephanie, our genetic counselors, because this is, as you have seen, this is a very complex process which involves a lot of disciplines, and even like women's mental health is involved in our support of the patients. So when you go to our website, you'll see all of the collaborations. This link will take you there. But all those things were, and also the support from other specialties. So I'm happy to take questions. So I think I have some time. Yes, please.
How do you know the men have the mosaicism?
So let's say if their blood is negative,
Yeah.
but they have like skin tumor or cafe au lait spot that's tested, and it showed NF1, a pathogenic variant, so we can tell that person is mosaic. But you know, Dr. Morales will probably get into that more in detail. And I'll follow up to that actually for the embryo genetic testing part too.
Okay.
So
I'm
please.
waiting for that call for sure.